I'm in our I am really excited to give this talk on medication abortion. This talk was born out of a few experiences I had in my clinic. I had a few patients approach me asking about referral to abortion services or whether I could provide abortion services. And I realized that I didn't know anything and I really wanted to. It's a topic I'm fairly passionate about personally. And also in light of sort of the current political climate and the way the rules are constantly evolving and changing, it's something I decided I would do a talk on. So great, so let's get started. I have a few objectives for this talk. My hope is that afterwards you should be able to describe who's eligible for medication abortion and how the process works. A big goal is that you'll be able to help care for people who are getting medication abortion, and that means helping to manage expected symptoms, testing for confirmed expulsion of pregnancy, and then referring to appropriate services or providers if you have concerns, and then provide a little bit in the way of resources for abortion care in Washington state. Huge apologies. I really wish this presentation could be more interactive, but there's such a dearth of training sort of in internal medicine that I have a lot of information to share. And so it's not as interactive as I would like it to be. And then just a quick caveat, this is not a talk on how to counsel people about sort of abortion, whether or not they should be pursuing it. It's not a talk on contraception, and it's not really a talk on procedural abortion, although we'll refer to that a little bit. These are all super important topics, just not in the scope of this talk. Okay. Just a few other disclaimers. I'm not an OBGYN. I've also never provided abortion care. And then I'll also say that this is kind of a touchy subject and people may have personal or religious objections to abortion. And the aim of this talk is not to persuade you one way or the other about whether you should be providing abortion, but rather how you might do so safely. And then the last thing I think is really important to mention is I'm going to do my best to use gender inclusive language. We often talk about abortion affecting women, but really it affects any person who is capable of becoming pregnant. Okay, so let's just start off with a few statistics. About 1 in 4 women will have an abortion by age 45. This number I'm aware of, but it always surprises me. And then I was able to find a few articles that said that roughly 500 trans and gender nonconforming people will have an abortion pretty much every year, which is a lot. It's a huge population of people. And then something else that's quite interesting is that most abortions happen fairly early on. So 2/3 happen before 8 weeks of gestation, and then about 90% occur in the first 12 weeks, which is really relevant as we discuss medication abortion. And patients who are eligible for medication abortion are so in the first 10 weeks. And so it's interesting to know that most people who are getting abortions are actually eligible for medication abortion. And then sort of an interesting milestone we just hit in the last year and a half, medication abortion exceeded or surpassed procedural abortion in majority, and they make up roughly now about 54% of all abortions, which is pretty interesting and kind of exciting. Okay, so if we could do a quick poll. I was a little bit delinquent and asked Nina and Javel to make a poll right now, but basically I'd love for anybody if they could just say yes or no, whether or not you've been asked by your patients to discuss or provide abortion services. I'll give it just like 30 seconds. This is mostly for me because I'm just curious how many of you have actually been approached about this. And Nina and Javel, I don't know which one of you is running it, but you can just let me know when like 75% of people. No, oh, bummer. Then 90% of you can tune out. Okay, but 10% of you have been asked, so that's pretty cool. All right, great. And then I guess if people feel comfortable taking 10 seconds in the chat, if you yourself have concerns or real questions that you have about approaching the topic of abortion. Maybe you have no questions and that's fine, but I'm just curious. Okay, well, I had a lot of questions, so I think we'll just move on in the interest of time. Okay. I don't even know where to start. Legal implications of providing. Great. Thanks, John. Okay, yeah, these are definitely some important things and things I had concerns about as well. Okay, so a quick slide on the laws in Washington. I was actually quite surprised to learn that Washington is a very sort of liberal and accessible state when it comes to abortion care. We have some of the least restrictive laws around abortion access, and so just a few kind of specific points. One is that abortion is permitted up until viability in Washington, and then generally that's it, understood to be around 23 to 24 weeks of gestation. And then in Washington, abortion can be provided by people other than doctors, and so that includes trained physician's assistants and NPs, which is pretty interesting. Ultrasound is not mandated. You may know that in certain states, ultrasound prior to abortion care is required, not necessarily for a medical reason, but to show the pregnant person their developing fetus and their pregnancy, which is very controversial, as you might imagine. Similarly, we have no mandated waiting period between counseling and actual provision of abortion services. There are a lot of states where there's a 24 to 48-hour waiting period, which places a huge burden on the patient. Parental involvement's not required for minors seeking care. And then as with most services, it was very hard to figure out the actual cost of a medication abortion, but it is roughly $500. Interestingly, in Washington state insurance, medical insurance plans are required to cover maternal and abortion care. However, there are several plans that have a religious objection and sort of abstention, including the Providence Health Plan, but the Department of Health will pay for the services if your insurance doesn't. So at least in Washington, the thought is that there is adequate coverage, but of course there are people who are not covered, who don't have insurance, who are maybe coming here from other states, which is sort of an interesting. Yeah, Priyanka says, wow, so different. Yeah, there's like a huge variety. And I'll just point you to the Guttmacher Institute, which is a really amazing resource. They provide information statistics on like every state in the country and how things are changing, and it's a great resource. Okay. Here's just a quick map of the abortion services that are available in Washington state. Despite everything I said, you might not be surprised to see that abortion care is really kind of centralized around the Seattle metropolitan area and then some of the other big cities, but there is a huge disparity and a huge area of need sort of in the middle and in between all of these states. And so people may have to drive very, very far. This was sort of sad to me, but also not that surprising. And I imagine it's probably not that surprising to all of you. This is a website you can kind of look up your zip code and where is the closest service to you. Okay, so let's get to the meat of this talk. So what is a medication abortion? So really there are two major types of abortion. There's a procedural abortion and a medication abortion. I think procedural abortion is more well known just because it's, I think, more commonly portrayed on TV and movies. But basically it involves the evacuation of the uterus with a device such as this one. It's basically a manual vacuum aspirator, and you attach it to a catheter that goes inside the cervix into the uterine cavity and basically removes the gestation that way.
Let's give it just a couple seconds. Hopefully Becca's connection comes back on.
I have absolutely no idea how you would go about confirming gestational age, especially like, does there have to be a formal ultrasound report, or is that something that has to be done in the clinic?
That's a great question, Luke. And I'm sure Becca will cover that. So I'll just say that you don't have to do an ultrasound. If she doesn't, we can talk more about it later too. Yeah. Will, I love the disclaimer about fair weather picketers. Thanks for sharing.
Oh my
She's
God.
back.
So sorry.
No worries, Becca.
Let's go back. Okay.
We
Oh,
were on the slide where you were discussing
yeah.
aspiration versus, okay.
Okay, cool. Let's get this. Let's do this again. Sorry, everyone. Thanks for being patient. Okay. All right. Okay, so I'll kind of move past this slide in the interest of time. But basically, you might not be surprised to learn that procedural abortion, it's sort of a one and done, one-stop shop. You go to the office and it gets done, and it's pretty easy to confirm that it's been completed effectively. And medication abortion is a little more private, so people are able to do it in the comfort of their own home. Sometimes the first medicine is taken in a clinic, but usually it's done at home and it takes a couple of days. But it's some people might prefer this. It's more just like having a regular period at home. Okay. It's my slides. So my slides are okay, Nina. You can see everything. Okay.
Yes.
Great. So let's just take a quick moment to talk about gestational age. So basically, it's based on the first day of your last menstrual period. I feel like I always forget this, and I'm like, wait, is there like a 2-week thing that you have to take into account? No, it's just the first day of your last menstrual period. And I think this is an important reminder that you are at least 4 weeks pregnant by the time you miss a period. And I just want that to like settle in, because I think we often forget that, just how quickly someone might need to get care. Imagine trying to get a doctor's appointment within like 5 weeks. Like that could be a little bit stressful, and actually and maybe impossible for some people. That this 10-week mark comes actually quite quickly. Okay, actually, I kind of want to go into presenter mode, so I'm going to do that if that's okay. Thanks for being really patient with me, everybody. This is kind of a mess. Okay. Thanks, Nina. Sorry about this.
You're doing great, Becca.
Thanks. Okay, cool. I think it's important to know too that you don't need an ultrasound to confirm gestational age or intrauterine pregnancy. This was a huge concern that I had when I was like, I could never provide abortion. I can't do ultrasound. I'm terrible at ultrasound. And I think it's an important reminder for everybody here that ultrasound is useful and important in certain circumstances, and we'll talk about them, but not necessary. There have been a few studies, especially in the last couple of years in the setting of COVID, that have compared people getting medication abortion with and without a pre-medication ultrasound to confirm intrauterine pregnancy and gestational age, and there are no differences in safety outcomes, which is really interesting and really exciting. This was this great study that was done in Contraception. I put the cover because I just think it's kind of funny that the cover of Contraception is just like very feminine flower. And I'll tell you a little bit about the Teleabortion Project, which was this really cool study that was done over the last 5 years, which looked at pretty much entirely remote abortion care. So medication abortion that was done entirely by mail. At the beginning of the study, they had patients come in for their sort of pre-abortion visit, but then they actually omitted that when COVID made going to the doctor a little bit dangerous. And pretty much they have shown that it's entirely feasible to do in many, many patients. Okay. Just a quick word on ultrasound. We do a lot of ultrasound that is way harder than abdominal ultrasound. And I think that's important to mention as well, that we learn how to do cardiac ultrasound. We put needles in necks. We do lots of things that are really hard, and this is not that hard. There have been a few studies that compare transvaginal ultrasound to transabdominal ultrasound. And at least if you're trying to confirm an intrauterine pregnancy, transabdominal ultrasound is just as sensitive. And I think that's an important thing to note as well, because a lot of clinics have regular ultrasound probes that you could put on somebody's belly. You don't need to have a transvaginal ultrasound to confirm an intrauterine pregnancy. It's not as sensitive when you're talking about gestational age. However, that's something that most of us are never going to be able to do. So I don't think that super matters for our purposes. And also, it's even if we were able to do a transvaginal ultrasound, it's much more invasive, it's less comfortable. And so if your goal is to look for an intrauterine pregnancy, and a transabdominal is totally fine. And I have just a couple images. The one on the left is a transvaginal ultrasound. And you can kind of visualize the cervix and the ultrasound, or sorry, the uterus. And this is the pregnancy. This is the gestational sac with the yolk sac inside. And then this is just a regular transabdominal ultrasound of pelvis that's not looking at a pregnancy, but this is the uterus and this is the bladder that's full of urine.
Becca, there's a question in the
Oh.
chat from Gina. Are
Yeah.
there risks in doing the medication abortion if the pregnancy is actually greater than 10 weeks? Like if we end up misstating the pregnancy with the info we have?
Yeah, that's a great question. I'll get to that a little bit later, but not really. It's just less likely to be effective. The other thing is that there have been lots of studies that show that patients, their recollection of their last menstrual period is incredibly safe and effective. Like people remember, and we should trust patients on that. And if they don't know, that's when you might consider sending them for an ultrasound to confirm, or sending them to a provider who is more has more expertise in ultrasound to confirm gestational age. Okay. Thank you for the questions, and thanks Nina for like popping in with the questions. Other myths about pre-abortion testing. RH status is really controversial. The American College of Obstetrics and Gynecology recommends testing and doing Rogram if it's indicated, but there are lots of studies recently that show that at risk of alloimmunization in the first 10 weeks is actually fairly negligible. And so it's not necessary. And these studies that took care of hundreds of people did not do this. The other thing is prophylactic antibiotics are not indicated, and serum HCG is not required, but it can be useful later, and we'll talk about that. And then pelvic exam is not necessary unless clinically indicated. So if you suspect an ectopic or something else, we'll get to that. Okay, let's talk about the medications a little bit. It's super simple. You take a pill of mifepristone. The patient, and this can happen either in the clinic or at home. The patient waits 24 to 48 hours, and then they take 4 pills of the misoprostol and they put them under the tongue or in the cheek, leave them there for 30 minutes. Almost all patients are sent home with a second round of misoprostol in case they don't have bleeding following the misoprostol, at which point they can take a second round of the misoprostol about 24 hours later. Okay. If you have been sleeping, please wake up. This is sort of the most important slide. I think this is important for everybody to learn, because whether or not you know this, you may have a patient that has had a medication abortion and they may come to you with questions about their symptoms. And so I think this is sort of the most important slide if you're gonna tune out. Usually bleeding occurs within the first 3 hours of taking the misoprostol, and that's that second medication. However, about half of patients will start to bleed after the mifepristone. That's in between the 2 medications. And usually it's just a really, really heavy period. And it's normal to see large blood clots. Many resources say up to the size of a lemon, which is pretty large. And then it's normal to see sort of clumps of tissue. I looked at several resources that said that it would not be expected to see fetal parts. I think that is a concern for people getting a medication abortion at home, but it's just too early in the gestation. In terms of controlling bleeding, it's safe to use tampons, pads, or menstrual cups, but pads are often recommended because they're easier to quantify. And then bleeding can last for a super long amount of time, up to about 70 days, but most people have bleeding for 2 to 2.5 weeks. Hey, sorry. Nausea, vomiting, cramping, and diarrhea, and a low-grade fever are very common for the first 24 hours. And then pain management, pretty much everybody says that NSAIDs are the best. Acetaminophen doesn't work. Unsurprising, I think, for most people who have had period cramps. And then to not take aspirin because it can make bleeding worse. And people are expected to return to a normal menstrual cycle between 4 and 8 weeks after taking this. Basically what this is doing is inducing a period. And so going back to your regular bleeding in 4 to 8 weeks is expected. Okay, so this is the money slide. Everyone else, you can go to sleep now if you're bored. Okay, great. Risks of medication abortion, it's actually incredibly safe. The case fatality rate of medical abortions is about 1 in 100,000. And I'll just mention that the number of reported pregnancy-related deaths every year is about 17 or 18 per 100,000. So carrying a pregnancy to term is actually far more dangerous. This is not a statement to say that one way or the other is better. It's just an important thing to consider. Really, the The risk of infection, of severe bleeding requiring transfusion is super rare. And then I would say the biggest thing is that there is a risk of medication abortion failure. So someone needing to go towards a uterine aspiration, having another dose of the misoprostol or something else. Okay. There are a few contraindications, but they're quite rare, and they include adrenal insufficiency or long-term steroids. If someone has a hemorrhagic disorder, you might understand why it would just be a little bit scary to have a big, like a lot of bleeding at home. If you think someone has an ectopic, if someone has porphyria, I have never in my life diagnosed porphyria, but it is a contraindication. And then allergy to any of the medications, or if you have an IUD. And it's not so much that it's dangerous if you have an IUD, it just might be more painful. So let's talk a little bit about ectopic. I know this was a big concern that I had about maybe prescribing medication abortion. It's actually a lot more rare than we, I think, expect it to be. It pretty much occurs in 6 to 20 out of every 1,000 pregnancies. Although studies are showing that that number is more towards the 5-6 range. And you should expect it if these symptoms arise, if someone's having abnormal bleeding, if someone's having a lot of pain and cramping, or pain in the shoulder, this might suggest that they have some free pelvic fluid. If someone is having weakness or syncope, again, that would suggest that maybe there's a hypovolemic state related to a ruptured ectopic. And then if someone has concerning physical exam findings like cervical motion tenderness or a palpable mass, I would say my pelvic exam, although I do them a lot, I'm not sure I've ever palpated a mass, but that would certainly be concerning. And then the following risk factors, which I've put here. And the other really important thing is that medication abortion, it's not so much that it would be dangerous to give somebody who has an ectopic this medication, but that it just wouldn't work. And so if your clinical suspicion is that it's an intrauterine pregnancy, it probably is, just statistically, and also you wouldn't necessarily be hurting them to do this. So I think that there's, like someone mentioned, like legal concerns for providing this service, and this is a consideration for sure, but just that it's not going to work, and it's not a treatment for this problem. That would be something else. Okay, I think there's a few things in the chat, Nina. I don't know if
John commented, never diagnosed porphyria in 25 years.
Yeah.
And then I had just mentioned also that you can use meso vaginally if the
yeah.
patient's having nausea and vomiting.
Yeah, for sure. Okay. Awesome. Another slide on kind of like expected course and when you should worry. So I've broken this up into the first 24 hours and then a week after taking the medications and then anytime. So in the first 24 hours, like I mentioned, it's super normal to have nausea, vomiting, low-grade fever, diarrhea. Basically, it's a prostaglandin analog. It's going to cause these symptoms. That's normal. But if you have a fever that's greater than 104 or higher for more than 24 hours after taking misoprostol, that would be concerning, mostly for an infection. And then for the week after you take the misoprostol, I would worry if the person had no cramping or bleeding. This would suggest that the medication either wasn't ingested properly or it didn't work. And then the other side of the spectrum is someone who has severe bleeding that's not getting lighter. And then here's something that I read a lot about. It's just like thinking that you didn't pass the pregnancy. This is actually like a highly sensitive symptom. And we'll talk a little bit about that on the next slide. And then another thing to think about is someone who's having pregnancy symptoms that are not getting better. So that's like breast tenderness, nausea, symptoms like that. In terms of bleeding, pretty much we tell people if you are bleeding enough to soak 2 pads an hour for more than 2 hours, that would be a concerning amount of bleeding, and we want you to come in for evaluation. And then if you have severe pain that's not relieved by NSAIDs or heating pads, and then other signs of hypovolemia like dizziness, vomiting, syncope. Okay. I have a quick slide on follow-up and confirming pregnancy expulsion. I think this is like a big concern of like, what if it doesn't work? Like I mentioned, it's very effective in about 95 to 99% of patients. And really what is recommended is that after the person has their medication abortion, that they have a 1-week follow-up, and that can be done either in the clinic or via telemedicine. They've studied this. and both telehealth and in-clinic in-person evaluations are safe and effective. And usually you would ask the patient the following questions. Did you have the expected course of bleeding? Did you pass clots? How many pads were you soaking, just to get a sense if they really had enough bleeding or if they had too much bleeding? Do you still feel pregnant? And then do you think you passed a pregnancy? These last two questions I thought were sort of interesting, but they come up again and again in the ACOG recommendations and also in UpToDate and some of the other resources that I found. The other thing for someone who's doing an at-home follow-up is that most providers recommend a high sensitivity urine pregnancy test at 30 days to sort of confirm. If there is suspicion that the person maybe didn't pass the pregnancy or it wasn't effective, then you might consider doing an ultrasound to confirm expulsion or do serial serum HCG levels. And this is when I mentioned having a baseline can be useful. You may remember from med school that the HCG is supposed to decline a certain amount over a certain amount of time, and that would be consistent with the pregnancy ending. And then ultrasound is a little bit controversial. It's normal to see some debris and a thickened endometrial stripe after someone has had an effective pregnancy expulsion, and that doesn't necessarily mean that they're still pregnant. So it can be easy. It can sometimes be easy to mistake a routine gestational sac for just debris. Okay. I wanted to include.
Becca, sorry.
Yeah.
There's a question from Jordan. How long is a urine pregnancy test expected to remain positive afterwards?
That's a great question. And it can remain positive for like up to 4 weeks, which is why they say to not take a urine pregnancy test before then. Just because you have a positive pregnancy test at 4 weeks doesn't necessarily mean that you're still pregnant. Sometimes it can take up to 5 weeks for the HCG level to become undetectable. Yeah, it can remain positive for a while, which is why they say like don't take it, 20 minutes after you've taken the misoprostol. Okay, a few words on incomplete or delayed medication abortion. This was really surprising to me. So there are a few ways to go. Most of the time, I learned that even if you have a routine gestational sac at 2 weeks after medication abortion, the majority of those patients will proceed to expel the pregnancy. It just may take a little bit more time. Oftentimes you can do, if it's like within the right time frame, if some of this before probably 10 to 12 weeks, you can do a repeat dose of the misoprostol to try to induce more bleeding and separation of the pregnancy from the uterine wall. And then most patients you would probably refer for uterine aspiration just to finish it. And then expectant management. Like I said, a lot of patients will actually go on to expel the pregnancy anyway. I would say that based on what I've read, most patients will prefer to be referred for uterine aspiration rather than waiting, because you can have ongoing symptoms of pregnancy like nausea, and just the anxiety of wanting to pursue the abortion and wanting it to be done with. And then ongoing pregnancy is a possible outcome. This happens mostly in patients who take the mifepristone and then change their mind. This can happen. And then very, very, very rarely the whole medication abortion is taken or done, or the medications are all taken, and then someone decides that they want to keep the pregnancy and the pregnancy is ongoing. There are certainly some teratogenic effects of taking these medications, but I decided not to talk about them because this is incredibly, incredibly rare. And you would certainly refer them to a higher level of care. Okay, so you might be thinking like, oh, cool, like this actually doesn't sound that hard. I can do this. And it's really disappointing that there is a big logistical barrier to doing this. And I saved this to the end for a reason. Right now, mifepristone is under the FDA REMS sort of program. It's the Risk Evaluation and Mitigation Strategy. There are several medications that are regulated by the FDA that you basically have to register for. And they're not medications that can be prescribed at or be dispensed at a regular pharmacy. You need to register with the mifepristone producers and the FDA to basically get a stock that you would dispense in your clinic or your healthcare setting. There are a few other medications that are under a similar restriction. They include things like clozapine and other certain long-acting antipsychotics. as well as certain monoclonal antibodies and biologics, which makes sense. You might need specialty pharmacy for dispensing those medications. I'll mention that the ACOG has for like over 5 years recommended and advocated for mifepristone to be removed from the FDA REMS program because they don't feel that it is medically indicated and that it is actually a really safe medication and we should increase access to this medication. I will also mention that you may have read that in the last couple of years in the setting of COVID, there have been restrictions lifted for these types of medications and for medication abortion to be provided virtually like anywhere. And basically that's because the FDA has temporarily suspended the in-person requirement of dispensing mifepristone. However, you still have to fill out the provider agreement form, and the patient still has to fill out a patient agreement form, and you have to still dispense this medication in a particular way. You can't get it at like a Walgreens. So I will say this is like a definite logistical barrier, but it is certainly possible, and I wouldn't be surprised if the laws like completely change in the next 5 to 10 years. Okay. I wanted to include a quick slide on health disparities. I think there are innumerable things you could say about abortion care and reproductive care in this country in general, and like this slide doesn't do it justice. But certainly restrictive abortion practices disproportionately affect people of color, people of lower socioeconomic status, and immigrants, and people who are uninsured. I think this is not surprising to anybody. It's the same with pretty much all medical care. But there have been a lot of studies, especially in the last 5 to 10 years, that have looked at places that have really restrictive abortion practice or policies, and they're associated with other poor outcomes like preterm birth, low birth weight, increased infant mortality, as well as increased maternal mortality. And that's sort of an interesting finding, and that's sort of independent of other factors. I'll also mention, and I talked about this at the very beginning, about certain restrictive abortion practices really limiting access. So things like mandatory waiting periods, ultrasound requirements, insurance coverage limitations that make it really hard for a lot of people to get this service. I don't think that's surprising to anybody, but it's just really worth noting. Okay, we made it to our take-home points. So 1 in 4 women and many trans and gender non-binary people will have abortions. Medication abortion with mifepristone and misoprostol is super safe in patients before 10 weeks. I certainly learned when I was doing this presentation that there were a lot of kind of myths about what is safe and what is not safe about before you do a medication abortion, things like ultrasound, RH status, CBCs, exams. Oftentimes these are not indicated and not required for safe medication abortion. And then, of course, there's this whole thing about the FDA REMS program. I think this may change. My hope is that it does, but we'll just have to see. And then there's been a lot of research in the last couple of years that fully virtual and telehealth provision of medication abortion is safe and may increase access to care. Okay, and that's kind of where I'm going to end. I want to have a huge thank you to Nina for like helping me narrow the scope of this talk, and then the awesome people in the Women's Health Elective for talking to me about this a little bit. There's a lot that I didn't include in this talk, but my hope is that when you guys move forward in your careers, you're going to see patients who have had abortions, and they may ask you questions, and it's good to be a little bit knowledgeable about this, even though you yourself may not be doing this service. And then I just have one more slide for some internet resources and clinics. I found these 4 resources to be really, really helpful. And then in terms of clinics, so for example, if you work at the VA, there is no abortion care there. And these are the services that these are the clinics that we refer people to. So Planned Parenthood, they have clinics pretty much all throughout Washington. And then the Cedar River clinics are reproductive health clinics in Seattle, Renton, and Tacoma. And then of course the UW family planning clinics at Roosevelt and Northgate are great clinics as well, and they do provide abortion care. Okay. I think I actually was ahead of time, even despite my internet breaking. any last minute questions? Let's see.
So there's the question from Gina about, was it pretty easy to register for REMS? And
Yeah, and it actually is not as hard as I thought. You basically, there is a provider agreement form. It's like 2 pages long. But pretty much you have to do it, and then you also sort of have to have like your clinic do it. So it's not just like you can show up at any clinic and be like, I'm going to do this. You kind of need backup from your whole clinic. But it's not as hard as I thought. I actually looked into it and I thought about putting a slide, kind of what the form looks like. It's not super complicated.
And so actually at UW, the way that it's done here, and I think at other places in the country too, is that there's sort of an institutional provider agreement. So it's under Sarah Prager, who's one of our OB-GYNs who specializes in family planning. So she has signed this form that's like, with Danco. And so anyone who's providing medication abortion within the UW system is actually sort of using that prescriber agreement form. So it is possible. So for example, our internists at the Women's Healthcare Center are operating under that prescriber agreement form. You don't have to have an individual agreement form.
Yeah. And then clinics at Harborview, actually, do they just refer them to the family planning clinic?
So the women's clinic at Harborview can provide it. I don't remember. I think that they still might have to like wait to get mifepristone like brought into the clinic. Last time I talked to them, they said that they try to bring the cases to family planning clinic because there's also like complex family planning fellows. And so it's just a matter of like making sure that people have the training opportunities, but I think they do have the capability at the GYN clinic at Harborview to do it.
And it's Anna, your point about the VA, it's kind of unfortunate because the VA insurance is basically like a federal insurance plan that doesn't cover abortion care. So even if you refer out, there's no, like, the VA doesn't cover any of it. And I'm not sure that the Washington Department of Health will cover it because it's a federal insurance plan. I'm not sure.
And I just want to put one more plug. So there's the family planning clinics that will do it within the UW system, but also, like I said, at the Women's Healthcare Center, your colleagues who are in the women's health pathway can also do this. They've been trained. And so if it seems like it's a straightforward and you've confirmed the last menstrual period, you could refer to the internal medicine clinic there. And, that would be a wonderful training opportunity for our colleagues too.
Yeah. Looks like Jordan has a question about fast track referral process. So I would say that the Cedar Rivers clinic, they see people pretty quickly. And then the family planning clinics at UW, they have, I think, 2 clinics per week, and they keep a lot of space open for patients like this. And so I would say access usually isn't an issue, at least when I did some afternoons there, and they really make it a point to try to get people in and save space for these patients. But that's a great question.
If there's ever an issue, feel free to email me and I can help make sure that someone can at least overbook them or something. Because that's one of the goals of these clinics is just to make sure that people have access when they need it.
What is this called if ordering an Epic? So do you mean referring to the family planning clinic?
Yep, that's what I meant.
It sounds like the UW family planning clinic is pretty much what it's called.
You just type in family planning into the order and it'll pop up, John.
Okay. Thanks, everybody. Appreciate your engagement. Thanks, Nina, and thanks for being patient with the internet Fakakta issue.